Today, we will be discussing the role of skeletal muscle relaxants and their role in respiratory care. There will be specific emphasis on their use in intubation and mechanical ventilation. Neuromuscular blocking agents, or NMBAs, are medications that cause muscle relaxation or paralyzation by interfering with the action of the neurotransmitter acetylcholine, or ACH. They can be divided into two groups: those that are depolarizing, meaning they directly bind with acetylcholine receptors, or non-depolarizing, which produce paralysis and muscle weakness by preventing the binding of ACH from occurring, thereby blocking the depolarizing effects of ACH and preventing muscle contraction. As respiratory therapists, we use NMBAs for the following purposes: to facilitate intubation, provide muscle relaxation with ventilated patients, such as those with ARDS requiring uncomfortable modes of ventilation, such as pressure-controlled inverse ratio ventilation or high-frequency oscillation, or high-frequency oscillation, or to enhance patient ventilator synchrony and reduce oxygen consumption in patients with status asthmaticus. Other uses are for patients with increased intracranial pressures who are intubated and to terminate status epilepticus and tetanus, and to keep trauma patients immobile while healing or during diagnostic procedures. To understand how these agents work, let's look at how they prevent muscle contraction. For non-depolarizing agents, they bind to and block the ACH receptors without causing depolarization, which means the receptor sites, once they are no longer occupied by the non-depolarizing agent, are reactivated. Therefore, these medications tend to be dose-related. With depolarizing agents, they open sodium channels and depolarize the postsynaptic muscle membrane like acetylcholine. They are much shorter acting as this mechanism occurs quickly. Non-depolarizing agents resemble acetylcholine, are poorly lipophilic, which means they don't penetrate well into fat tissue, are poorly absorbed in the GI tract, so they must be given IV, are dose-dependent and have a longer duration than depolarizing agents. Duration is affected by older age and hepatic or renal failure. In these cases, the effects will be seen longer. When normal conduction is restored, 75% of the receptors may still be occupied, so further boluses will cause a longer response. Some examples of non-depolarizing agents are pecuronium, which has some hepatic metabolism and is eliminated primarily by the kidneys, and vincuronium, which is primarily metabolized in the liver and relies on the kidneys for secretion, and in renal failure can cause prolonged paralysis. Other non-depolarizing medications, including atracurium and cisatracurium, are eliminated differently than the aforementioned medications. They rely on a degradation mechanism termed Hofmann degradation, which is dependent on blood pH and body temperature. Therefore, they are good choices for patients with renal or liver failure. Some of the adverse effects of these agents include decreased vagal response, resulting in increased mean arterial pressure and tachycardia, with pancurium having the most cardiac effects. They also release histamine, which, as we have discussed previously, is released by a burst mast cell and can cause bronchospasm. And lastly, since the diaphragm and intercostal muscles are also paralyzed, the patient may have inadequate ventilation, even with mechanical ventilation. To reverse the effects of non-depolarizing agents, we turn to medications which inhibit cholinesterase, which is the enzyme that breaks down acetylcholine, and therefore allows more acetylcholine to bind to the receptor site instead of the non-depolarizing agent. Medications that fall into this category are neostigmine, edrophonium, and pyridostigmine. Now let's look at the only medication in the depolarizing agent category. That medication is succinylcholine. It is shorter acting than our non-depolarizing agents, and there is no agent to reverse it. Paralysis usually occurs in 60 to 90 seconds and lasts for approximately 10 to 15 minutes, making it ideal for intubation in awake or semi-conscious patients. Succinylcholine depolarizes the muscle membrane similar to acetylcholine, but has the unique feature of causing fasciculations, which are muscle twitches on initial bolus. As stated before, there are no agents available for reversal of succinylcholine. Some of the side effects and hazards of succinylcholine are vagal responses, more often seen in children, muscle pain, soreness, histamine release leading to bronchospasm, hyperkalemia, increased intracranial optic and gastric pressures, increased heart rate and blood pressure, sympathomimetic effects, and malignant hyperthermia, which results from an uncontrolled release of calcium from the muscles, resulting in intractable spasms of the jaw, rigidity, increased oxygen demand, high body temperature, metabolic acidosis, and tachycardia, and is often life-threatening. It is treated with dantrolene and can be reversed if caught early. For all patients receiving NMBAs and on mechanical ventilation, these potential complications must be monitored. Proper eye care to prevent drying of eyes, good pulmonary toilet including suctioning to prevent nosocomial infections and mucus plugging, proper sedation and pain control, checking for decubitus ulcers and potential for deep venous thrombosis, DVTs, which all result from lack of muscle activity. Pain control and sedation are absolutely mandatory when administering NMBAs. For pain, fentanyl or morphine may be used, and for sedation, propofol, lorazepam, or midazolam are often used. Patients should be monitored for tachycardia, hypertension, diaphoresis, and tearing, as they can alert us to the possibility of anxiety caused by inadequate sedation or pain control. It is unthinkable to paralyze a patient on mechanical ventilation without these measures in place, as patients receiving NMBAs are still fully conscious and are fully aware of pain sensations. There are many medications, conditions, and diseases that can interact with NMBAs. Of interest to respiratory therapists are antibiotics such as vancomycin, theophylline, metabolic acidosis, and neuromuscular diseases. All patients on NMBAs should be monitored, and of particular concern is to always rule out other causes of ventilator-patient dysynchrony, such as ventilator malfunction, improper ventilator settings to meet patient demand, or other underlying causes or agitation. Lastly, there is a new NMBA in the pipeline called gantracurium, which is a non-depolarizing agent with rapid onset and short-acting that is better for patients with organ dysfunction. Also, there is a new reversal agent being studied, sugammadex, which reverses rocuronium and vecuronium, but is less effective on reversing pancuronium and succinylcholine.